Good morning, everyone. We thank you for joining us today, whether you're here in person or joining us via streaming video for this Grand Rounds presentation on delivering equitable healthcare through the use of multilingual discharge instructions. And for those of you who don't know who I am, I'm Rob Gajarski. I am actually the Section Chief of Cardiology, and it is my distinct pleasure and privilege to introduce my colleagues who are going to be speaking today. So Rick Fernandez joined the team at Nationwide in 2011, and he's one of the attending physicians in the cardiac ICU, and he's also the co-director of the Heart Center Simulation Program and an assistant professor of clinical pediatrics at The Ohio State University. Dr. Fernandez's area of interest includes medical simulation, cardiovascular physiology education, interprofessional education, and mechanical support simulation. He completed his medical degree and residency in internal medicine and pediatrics at the University of Illinois in Chicago, and then did a combined fellowship in peds, critical care, and cardiology at Northwestern University Lurie Children's Hospital in Chicago. Maria Sanchez is a certified pediatric acute care nurse practitioner. She received her Bachelor of Science in Nursing from Mount Carmel in 2016, and then she continued her education and then got a Master's of Science in Nursing from Ohio State in 2019. She started her career at Nationwide in 2016, and she's worked in the inpatient cardiology and cardiac ICU for the past 5 years. She's a member of the National Association of Pediatric Nurse Practitioners, Pediatric Acute Care Cardiology Pediatric Cardiology Care Collaborative, that's PAC3, the American Academy of Pediatrics, and her primary interest in the care is the care of critically ill children with congenital heart disease, as well as nursing and provider education about health equity research, and quality improvement. So thank you too for your presentation.
Thank you for coming. So I would like to start out introducing this project by sharing a story that demonstrates the importance of utilizing standardized discharge instructions in written form and translated in multiple languages. This is a story about a patient and her family's experience of discharge here at Nationwide Children's Hospital. It is about a 9-year-old female patient who was taken to the emergency department after being struck by a car while riding her bicycle in her neighborhood. Her parents were Spanish speaking. At the time of discharge, she was taken to surgery after that emergency department visit, and the surgeon placed over 20 stitches to her leg. At the time of discharge, her parents were given verbal instructions about incision care, pain control, when to seek medical attention, and also about the follow-up appointment when they plan to remove the stitches. I would like to remind you that the parents received verbal instructions and also add that an interpreter was not used. About a month later, that patient was seen at an urgent care visit because she was having persistent pain. At that visit, the providers found out that the parents were performing daily incision care, which was not necessary and likely contributing to the pain that she was experiencing. They also had missed their follow-up appointment that was supposed to be 2 weeks prior to the urgent care visit. We will come back to this story later on in the presentation.
Good morning, everyone. So we'll be talking today about delivering equitable healthcare through the use of multilingual discharge instructions. We have no disclosures to report, but before we get started, I want to ask you guys to think back over the past, let's say 2 or 3 weeks in your clinical practice. I wanted you to think back, and have you worked with any patients, any families, for whom English is not their first language, where you needed to use an interpreter, either a virtual interpreter on the telephone or in person, to communicate their healthcare instructions, their diagnosis, their prognosis, information about their follow-up, things like that. When you got up from that encounter and when you walked away, can you say that you're 100% confident that that family walked away understanding completely everything that you explained to them through an interpreter and everything that, all the instructions that were given, all the explanations that were given about their disease process or their diagnosis? What I'd like to talk about today, what we're going to talk about today, is just that. We're going to look at some of the existing literature on the impact of language barriers on healthcare outcomes. We're going to talk about our experience here at NCH in one specific area, right, in cardiology. They don't let me out to other places very often. We're going to describe our innovation for addressing disparities in our own unit and delineate prospective plans for improving healthcare outcomes for our patients. And then through all of this, I want to encourage you to think of ways that you can model the strategies that we're going to describe and adapting some of these tools for your own practice in your own areas within the hospital. Before we get started, let's just talk about a few definitions. First of all, what do we mean when we talk about health equity? And basically what we're saying is that everyone's going to get a fair shot to be as healthy as possible, regardless of race, ethnicity, etc. When we take that and we try to apply it to our practice here at Nationwide Children's Hospital, what we're talking about is creating a health equity culture, right, here at Nationwide Children's, where our goal is to have zero disparities in quality, clinical, safety, and service work areas across Nationwide Children's Hospital, so that our outcomes, there's no disparity in outcomes based on race or ethnicity or other differences. So that means that when we look at our service lines and we look at our processes within our areas, we're looking at them through the lens of, of health equity and diversity. I don't want to make it seem like this is a problem that is unique to us here at Nationwide Children's Hospital. All right, this is an issue that everyone's dealing with across the country and across the world. There are persistent disparities in outcomes along the lines of race and ethnicity across a number of different areas: infant mortality, adolescent mortality, outcomes for chronic diseases like asthma and obesity. And the brunt of those disparities are borne by immigrant families, by families who don't speak the language of where they're receiving care. You'd think that as you're advancing, as you go from the outpatient setting to the inpatient setting in a more controlled environment, that those disparities would be decreased, mitigated, right? And yet we know that here in the United States, there are still disparities in the outcomes, even in the pediatric ICU, and looking sort of more in my own backyard, even within the cardiac intensive care unit and in the care for patients with congenital heart surgery. Looking at Richardson's data a little bit more closely, they actually found that for patients who have congenital heart surgery, there are a series of mediators that can lead to increased mortality. They identified a broad range of things that impact that increased mortality. We picked one to sort of focus on for ourselves, and that is language barriers and how those affect our patients. There is some data out there on language barriers and how we mitigate them and how we deal with them in healthcare. This study in over 4,000 patients told us something that in a very fundamental way makes sense. If you give someone discharge instructions in the language in which they speak, they will understand their healthcare better. It seems kind of obvious, but they were able to show that very clearly in this study, where families given language concordant discharge instructions had far fewer questions about their medications, their follow-up, or whatever they had been, their diagnosis. This sounds amazing, but there are barriers too. It's not quite that easy. When we talk about the barriers to overcoming language differences, there are things like unusual languages that are not sort of common in the area, and so trying to find an interpreter for those languages is challenging. I think something that we certainly struggle with, and I'm sure you guys have too, is trying to line up the healthcare providers and the interpreters or interpretive services, and trying to have everybody in the room at the same time so that you can get as much information to the family as possible through the interpreters. Additionally, adopting sort of different technologies, even just adopting the use of interpreters is something that needs to be disseminated within the culture of a healthcare institution, and that's a challenge. It seems like the solution to a lot of things these days is to switch to AI and see how AI can help us in this. And certainly groups have looked at that. One of the AI formats that has been out there longest for translating things is Google Translate. It's very convenient, it's in your pocket. And what this group found was that Google Translate works well for common languages, and works well for sort of easy topics. As the medical topic becomes more complicated or the language becomes less common, then the fidelity of the translation drops off precipitously and is not as effective. And sometimes, as this study shows, when you have the resources, you have translated documents, you have them in a relatively convenient place, sometimes workflow just overwhelms the process. And what we see here is we have the completeness of written discharge instructions. If you were English speaking, most of you, 87% of English speaking discharges had complete discharge instructions versus 16% for the non-English speaking patients in this study. And what's, in my opinion, a little bit worse is that not only did the non-English speaking patients not have complete discharge instructions, when they did have discharge instructions, they were in English and not in Spanish. It was a very small percentage that received full discharge instructions in their own language. So we know that this intervention helps. We know that we have fixes for this, but we do struggle with implementation. With this in mind, we asked ourselves, okay, how can we do better? What can we do in the Heart Center to overcome some of these things? How can we improve comprehension of discharge instructions, improve the healthcare knowledge of our patients, and not just of our non-English speaking patients, but all of our patients, right? And we thought, what if we could provide discharge instructions that are language concordant, English and other languages, for all of our patients and families in their language and specific to their congenital heart disease, their procedures, their interventions and diagnoses. So before we embarked on that journey, we said, well, let's take a look at how we've done so far. Let's look back a little bit. And so we did a retrospective cohort study to look at our experience in the Heart Center. We looked at about 3,400 discharges between 2017 and 2019. We chose those years to sort of mitigate the effects that COVID might have on that. And out of those, we preliminarily did a chart review to identify age, cardiac diagnosis, and the type of discharge they were, whether they were medical, post-operative, post-cath, et cetera. In that group, we identified 180 non-English speaking discharges, so about 5% of the discharges. And then we matched those with 357 English speaking controls. And they were matched on the age, cardiac diagnosis, and the type of discharge in order to sort of make sure that we're looking at the same types of patients with this similar type of prognosis. Once we identified those patients, we picked a couple different times in their healthcare to look at some specific issues. We looked at the time of discharge, and we looked at whether discharge instructions were a review of discharge instructions was documented, review of medications was documented, review of follow-up was documented, and we also looked to see if there was documentation of use of an interpreter. In the time between their discharge and their first clinic visit, we looked at hospital readmissions, urgent care use, ER use, telephone encounter use. And then at their first clinic visit, we looked at, as sort of a surrogate for how well the family understood the instructions they were given, we looked at discrepancies in how medications were being given, prescribed versus how they were given, dietary instructions, how they were prescribed versus how they were given. Our study population, when we looked at the non-English speaking patients and families, you can see that the bulk of them were from one of 4 language groups: Spanish, Somali, Nepali, and Arabic. And then you can see that there are quite a few languages that are spoken here at Nationwide Children's Hospital. This patient cohort matches almost identically what we see across the institution in these same years. You look at our discharges, the bulk of them were medical, and followed by surgical and cath and EP, and then we had a small percentage that were other procedures like G-tubes and other diagnostic studies. When we looked at their hospital length of stay, you can see the length of stay was in fact longer for our non-English speaking patients than it was for our English speaking patients. It was 18% longer across all discharge types, 30% longer among the medical, and 5% longer among the surgical. When we looked at their review of their discharge instructions, we found that only 62% of English-speaking discharges had documentation of their discharge instructions being reviewed with them. And similarly, 66% of non-English speakers had their discharge instructions reviewed for them, had documentation of it. But in that group of the non-English speakers, only 36% had documentation of the use of an interpreter. Similarly, when we look at medications, it's a similar pattern where we have 65% reviewed in English speaking, 54% in non-English speaking, but only 43% of those had an interpreter. And follow-up plans, only 32% had an interpreter. So we look at the hospital, now we've discharged them, they're out of the hospital, and now we're looking at their healthcare utilization after they leave. Right? When we look at differences between hospital readmission rates, we see that there's slightly more readmissions for our non-English speaking patients than our English speaking patients, but it's a small difference. When we look at emergency room visits and urgent care visits especially, we see that there is a significant difference in those two groups, in those two areas, where our non-English speaking patients are having to return for healthcare visits, unexpected healthcare visits more frequently after discharge than our English speaking patients. And this was a little bit of a surprise. I think we made some assumptions beforehand, but it sort of makes sense. When you look at telephone encounters between discharge and your first visit, these being telephone encounters is like, I ran out of my meds, my baby's lips turned blue, what should I do now? Joey's been fussy, should we bring him in or not? We see that there was significantly fewer non-English speaking patients than English speaking patients using the telephone encounter, using the cardiology triage line. We move now from the sort of between period into our follow-up visits. We see a big discrepancy in terms of medications and in terms of diet. In terms of medications, 20% of our non-English speaking population had significant discrepancies, wrong schedule, wrong frequency, wrong dose, giving meds that were no longer prescribed, or giving them in a way different than how they were instructed. And similarly, when it comes to diet, you have a significant proportion of our non-English speaking patients preparing formula incorrectly, using the wrong formula, et cetera. Equipment discrepancies, how the pump is set, if they're getting NG or NJ feeds. And so there were larger discrepancies there. We have to ask ourselves that consistently across all these questions, there are differences. And why do we think that is? We tried to mitigate differences that would be related to the complexity of their disease, the complexity of their congenital heart disease, complexity, things that come up because of different ages. And so when I look at this data, I think, all right, well, clearly we're not conveying information, we're not conveying instructions, or we're not hearing, perhaps, the concerns of our non-English speaking patients. And so with that in mind, we sort of proceeded to design an intervention to help that out. I'll hand it over to Maria to describe that.
So now let's talk about our intervention here in the Heart Center. In an article by Davis that was referenced earlier in the presentation, it was demonstrated that standardized written and translated discharge instructions improve caregivers' understanding and also patient outcomes, especially when paired with verbal instructions. That is why we decided to focus on improving the after-visit summary. We wanted our discharge instructions here in the Heart Center to be standardized, to be disease-specific, and procedure-specific to the procedure the patient underwent here in the Heart Center. We not only wanted those instructions to be available in English, but we also wanted them to be translated into our 4 top non-English languages that we see here in the Heart Center, which are Spanish, Somali, Nepali, and Arabic. We wanted them to be built in Epic in such a manner that they would be smart phrases, dot phrases, and smart text that could then be embedded by the providers in the free text section of the after-visit summary. We wanted them to be user-friendly so that our providers would be able to utilize them for our patients and their families. We wanted the instructions to be built in such a manner that would auto-populate information that has been pre-built, and also for providers to be able to choose from selections from a select all that apply, multi-option selection, or either-or instructions, depending on the patient's hospital course and if it was appropriate for them. And in so, we wanted to deliver personalized, disease-specific, procedure-specific, and bilingual discharge instructions to all our patients, so that our English-speaking patients would go home with standardized discharge instructions, and our bilingual or our non-English-speaking patients would go home with bilingual discharge instructions in order to mitigate some of the disparities seen with language barriers, and therefore also improve the comprehension of instructions for all our patients. As we conceptualized this project, in designing a better after-visit summary, we realized we needed 3 essential components. One being a standardized format, a format that would be standardized across all instructions. All instructions would include facts about the condition, information about the hospital stay, plans for care at home, follow-up, and contact information. For patients who are non-English speaking, we wanted these to be in a bilingual table format. Second, we wanted the content to be specific to the patient population. Here in the Heart Center, we wanted it to be cardiology focused, disease specific, based on the cardiac diagnosis, and also procedure-specific based on the procedure the patient underwent. Third, we needed stakeholders. Stakeholders that are essential in working together to bring an idea and transform it into an implemented intervention. This process can be adapted in any clinical area here at Nationwide Children's Hospital. And as we were working with the process and how it came along, we thought that, we thought, and one would think also, that this would be a very simple project to take. But in actuality, it took us 4 years to develop this intervention. In 2021, this is where we came up with the idea to improve the after-visit summary. We identified stakeholders and our necessary resources. We knew we needed the assistance of the EPIC team, translation services, our contact experts, pharmacy, as well as other members of the Heart Center. In 2022, this is where we delve into the details. We design our product, our discharge instructions. This year, we started working with translation services so that their team would be able to translate our discharge instructions. And we collaborated with EPIC and Nursing Informatics for them to help us build these instructions into EPIC for us, the providers, to be able to use. And we worked with our content experts, which included our cardiologists, our nurse practitioners, dietitians, discharge planners, and the lung transplant team as well. In 2023, this is where we started integrating our intervention. After translation services had professionally translated our discharge instructions, the EPIC team helped us build them into a bilingual table format in EPIC for providers to use. During this year, we applied for IRB approval and grant support. And during that process, it was very interesting. We identified an issue with the electronic consents here at Nationwide Children's Hospital. For patients who are non-English speaking, there's a limitation on the number of patients who are consented and are actually enrolled in discharge studies, in research studies. So we worked very closely with our research coordinators and translation services to come up with the solution to address this issue. And during this year, this is where we started collecting our retrospective data as well. And now, here we are in 2024, where we are finishing out the rollout of the bilingual discharge instructions. We started with English, followed by Spanish, Somali, Nepali, and we are currently working on the Arabic instructions. We have completed some of the Arabic instructions, but we are working on finalizing the rest of them. We also completed our retrospective data that Dr. Fernandez just shared with you. And we have started enrolling patients into our prospective study here in the Heart Center. Like I mentioned, 4 years ago, this is where the idea began. And 4 years ago, here in the Heart Center, we had 4 generic discharge instructions. One that was a generic after-visit summary, one on supraventricular tachycardia that was overall very generic, some instructions on post-operative care, and then post-catheterization. But now, because of this intervention, we have 39 condition-specific and procedure-specific instructions here in the Heart Center. Not only are they available in English, but they're available in Spanish, Somali, Nepali, and Arabic. Along with that, we also created 22 dot phrases that are also available in all languages, and they are live in every language, including Arabic. These are dot phrases that can be used in combination with the smart text instructions regarding formula instructions, feeding plan, home care company information, contact and follow-up information for patients and families. Not only can they be used in combination with the smart text for additional information, but they can also be added alone in terms of, let's say, for example, you have a patient that comes in and we don't have a smart text available for them, but at least, say they're Spanish speaking, at least we can provide them with the contact information for them to refer to in their preferred language. I would like to show you here a smart text and how that looks from a provider standpoint. Here are some instructions for a patient, English-speaking patient, who is admitted for treatment of supraventricular tachycardia. As you can see, there's a section that talks about the condition, facts about the supraventricular tachycardia, and also it's followed by subsequent sections that include pre-built selection of things that we commonly do here in the Heart Center. I want you to focus on the test completed in the hospital section, where you can see that there are pre-built options for providers to select from, and after they're selected and right-clicked, then the information will auto-populate. This is meant for providers to be able to select what is applicable to their patient based on the patient's hospital course, and make it easier for everyone to use. Here, I want to show you the view of what it looks like in a bilingual table format. This is for a Spanish-speaking patient. And in the next slide, I'll go over a little bit more detail, but essentially, this is the view that the nurse will see prior to printing the bilingual discharge instructions for their patients. This is the view that the parents and patients will see at the time of discharge after the instructions have been printed. As you can see, they're built similarly like the English instructions, where the format is very standardized. And also, the English instructions are on one side, and the corresponding direct translation of those instructions are on the other side. We built these instructions purposely in a bilingual table format for non-English speaking patients. One, from a nursing perspective, we wanted the nurse to be able to instruct their patients and be able to know by reading the English instructions what they're instructing their families about. We wanted them to then be able to, with the use of an interpreter, complete a teachback with the parents after the parents or patient had read the instructions. For a nurse, if these instructions were only built in one language, say Spanish, and the nurse, if he or she does not know how to read or understand the language, then he or she would not be able to instruct the family successfully about the discharge instructions. From a translation services standpoint, this is actually the preferred method of providing translated documents to our patients and families. Anytime that we are translating a document, we should be providing the English translation of that too, not just one document. From a parent-family perspective, we thought that this would be beneficial because they would be able to ask clarifying questions. For example, say that they had a question about the second bullet point under test completed in the hospital about stress tests. They would be able to look and read their native language or preferred language, point at it, and ask the nurse for some clarification. The nurse will then be able to line up the bullet point to the English translation and attempt to clarify the questions that the parents might have with the use of an interpreter. And if he or she is not able to, then they would then seek the provider for additional clarification, so that the parents would then have a comprehensive review of the discharge instructions and make sure that there's no questions before they left. We also thought that, for some of our families who have limited English proficiency, as they are learning and navigating through the English language, this would be beneficial because they can read the instruction in their language, and then as they're learning English, they'll have the direct translation that was professionally translated by our team. And also, patients and families would then be able to have instructions in their preferred language that they can refer to at a later time. So right now, I want to take a pause to reflect upon the story that I shared with you at the beginning of the presentation. Remember the 9-year-old female patient who was admitted here at our hospital, Nationwide Children's Hospital, after being struck by a car, underwent surgery, whose parents were Spanish-speaking, and who were sent home with verbal English instructions. Can you imagine if the family was sent home with instructions that were in their preferred language, how that may have impacted the incision care that the parents were performing daily? If it had been clarified in their instructions how often to perform that, perhaps they wouldn't be doing it daily, and perhaps the pain that patient experienced may have been less. Or perhaps they would have not missed their follow-up appointment because hopefully they would have had it written in their instructions. Well, that 9-year-old female patient was me 21 years ago. And if my parents and myself would have been sent home with similar instructions that you see here on the screen, then my care at home would have been significantly impacted. I feel that had my parents 21 years ago had this, they would have read it, make sure that they were doing incision carefully and only when instructed. And I feel that my pain probably would have been a lot less than I experienced 21 years ago. The scar that this has left me acts as a reminder and adds to my passion to continue to do the work that we're doing. But not only, the scar, truly the whole experience, this whole experience that I had 21 years ago has left a lasting impression in me and compels me to continue to do work that will help and benefit many, many patients now and in the future. And to be clear, these instructions here in the Heart Center is our new standard of care. Patients who are being discharged from the Heart Center will be sent home with standardized discharge instructions, not only in English, because they didn't exist before, but also for those patients who are Spanish, Somali, Nepali, and Arabic, and I hope someday even more. Moving forward, we want to study our intervention. We want to see if this is going to be impactful. We want to collect objective data, not just have subjective data from my experience. We want to see, is it going to improve healthcare outcomes? Is it going to impact patient and family satisfaction for not only English-speaking, but Spanish, Somali, Nepali, and Arabic-speaking patients? With the use of research, we are evaluating these questions. We have had IRB approval and grant support for the prospective study that we are currently doing. As I mentioned earlier, these instructions are the new standard of care. Regardless of this study, we will be administering these instructions to our patients and families that are disease-specific, procedure-specific, and available in 5 different languages. However, for those patients who we approach, consent, and who agreed to our study, we will be providing them with a survey at the time of discharge, asking them in questions in their language in a bilingual manner about their satisfactions with the instructions and also their understanding of the instructions. We want to learn from them to hopefully make things better if we need to. For those patients who go home with bilingual discharge instructions, we will also be asking them questions about their interpreter's experience here during their hospital stay. Similarly, we will be administering a second survey with similar questions at their first cardiology follow-up visit. And we will be following these patients long-term. We will be evaluating their healthcare utilization and see if there's any differences in regards to urgent care visits, emergency department visits, readmission rates, and also evaluate to see if there's any discrepancies in medication and dietary instructions after they have been given these instructions in their preferred language. So to conclude, we are more equitable now here in the Heart Center than we were before, as we have personalized discharge instructions that are specific to the disease, procedure, and available in 5 languages. And as an institution, we are more equitable now than we were 21 years ago, but we can do better. We can improve the healthcare outcomes, the health literacy, and the care that is received at home, not only for our English-speaking patients, but for our non-English-speaking patients. Here at Nationwide Children's Hospital, we have resources, but most importantly, we have very caring, enthusiastic, intelligent individuals that can come together and collaborate to be able to create interventions and innovations that can help to deliver better care to our patients and families and hopefully have impactful outcomes in their health long term. Like we say here at Nationwide Children's Hospital, when your child needs a hospital, everything matters. And in fact, everything does matter, including the instructions that we provide to our patients and their families at the time of discharge. Like I mentioned, we have resources here at Nationwide Children's Hospital. And now that we have a process that we have implemented, we're utilizing, and it's working, this can be used and adapted in your clinical areas. We actually encourage you to do so. We want you to please reach out, because we would be happy to help you, because the more we are able to disseminate these types of instructions for our patients and families, the more we will impact lives, and that's what we're here for. And lastly, I want to take a moment. We want to take a moment and acknowledge everyone who has helped us create this intervention and become a reality. Without every collaborator, this wouldn't have been possible. It took a village, and it's still taking a village, and we're working very hard. But thanks to everyone within the Heart Center department, the research coordinators, translation services, our EPIC team, nursing informatics, this wouldn't have been possible. So thank you very much.
Thanks so much, Rick and Maria. That was a fantastic presentation and very, very timely. We are going to invite questions from the audience as well as those people online. We already have a few questions from people online that I'll get to in just a couple of minutes, but I wanted to make a couple of additional concluding comments. This is incredibly, incredibly important work. We want to congratulate Rick and Maria on all the accomplishments that they have made. And I know for a fact that Maria has put countless hours into trying to make all this come to fruition. And like she said, it does take a village, but it was really, really important that she's been able to spend this time. This was her brainchild, and she has made this come to fruition. And a lot of it, I think, is based on her previous experiences, which are lifelong, clearly, so that we can have a significant impact on our families. If we take some of these comments that have been made to heart. The other thing I wanted to just take a minute to comment on is that this work is important for people who are being discharged. It's important for people who are going to be on the outpatient setting. But there's also another project that's going on in the Heart Center that I just wanted to call out that may be applicable across the board. One of the other cardiologists, Dr. Julie Aldrich, is currently doing a project with Maria and team where they are now trying to implement the use of an interpreter on rounds, because it became very, very clear, just as in this data with discharge instructions, that a lot of conversations occur during rounds without the use of an interpreter, and families are often left with a lot of unanswered questions and a lot of fear because they don't understand what's going on, and that leads to a lot of unnecessary angst among families. So there's a whole project now going on to try to incorporate interpreters during rounds. You may say, well, we should already be doing that. Why isn't that being done? And more to come on this, but there are a lot of reasons why it doesn't always happen. But I think that's going to be an important incremental step in trying to provide equitable health care to our families, both while they're inpatients and on the outpatient side. So just before we get started in the room, I have a couple of questions from the online people that I will bring up. The first one is from one of our critical care colleagues, Jen McDonald, who says that this is a great project to meet such a huge gap. I have had a couple of families tell me that they prefer to have English instructions that a provider goes over with them with an interpreter rather than translated instructions. They felt that was actually better for them. And the question that Jen asks is, do you have any plans to capture the family experience with your work to make sure that we're meeting their needs, since apparently not every single family needs to have that in written format?
That's a great question. That was part of the reason, as Maria pointed out, that we chose, rather than just providing the discharge instructions in the language of, the preferred language of the family or the patient, that we chose to provide it in both languages on the discharge instructions. That way, excuse me, that way they would have both available to them.
And then just to add too, so it is true, we've actually had some patients as we are approaching families who are not English speaking who have said, I do also want the English version, and when we present, say, we will provide them in bilingual format, they're like, oh great, because that way my husband can read them in the language, and then my children, who will help us with understanding the information, will be able to read it in English. Interestingly, one of the things that we've been learning here just recently is that our Somali-speaking population, actually, some of them do not read. And so, you'd think, well, we're providing instructions in the Somali language and they can't read them. Well, that's, because of, finding out these information, talking to families, there's other interventions that we'll be introducing at a later time.
And I will take some questions from inside.
This was a great presentation. I think it's really important to reflect, you kind of zinged us with the case of where it came from, but it is really important. This initiative came from a patient who happens to now be a staff member. And having older adults, parents who have been in a room speaking English with their surgeon or with their, for their care, and I quietly sit in the background and not tell the surgeon I'm actually a physician, and then ask my parents, what did you hear? They didn't hear half of it. So I think one thing that is really important, you point out, a patient experience generated this. To what extent are you having patients involved all through the process? I mean, you showed that first slide in 2021, stakeholders, parents, patients should be at that point. We are assuming way too much, like you pointed out. Somali families, how many of our families have an adequate reading level? I know in primary care clinic I worked at, it might be 5th grade, and probably a third are not even have that level of reading. So I think it's really important to understand this, to engage them right up front. To that point, low literacy type of interventions are well received. We had asthma instructions that were black and white, and someone changed them to red, yellow, green. So think about your post-operative instructions. This is green, this is what's expected. This is yellow, be aware of it. This is red, call us. People understand traffic light concepts in very low literacy approaches, and that doesn't offend people. I mean, we can't take education level equivalent to health literacy, as in my own experience with family members who totally went over their head. So, but great work here and wonderful to see. It might be interesting to even see how families respond and randomly assign them to instructions in black and white and some in that, just experimentally, and see if there's better recall. So.
Thank you. That's a great suggestion, and certainly something that from the inception of the study we thought, okay, well, we can do this, and this is what we think we need to do, but from the moment that we thought of improving the discharge instructions, we said, well, we should look forward and look at how our families receive this. What are their experiences with the discharge instructions? What are their experiences with the interpreters in general, and during their admission? And so that's part of the prospective piece of this, is to say, okay, we're going to start doing this. Let's take a look forward. and see how this is being received. It is sort of interesting. This is purely anecdotal. This is not based on any numbers. Don't quote me on this. It is very interesting that we looked back between 2017, 2019, we found 180 discharges over the course of 3 years. It does not seem like that much. As we have tried to implement the prospective arm of this study, we were gauging that we were going to have the same numbers. So we were like, oh, we'll only need this many people to help us. We'll only need this much stuff. We'll only need that. We have been overwhelmed and have actually had to sort of pace ourselves because the population of our population in general has grown. And along with that, our population of non-English speaking families have grown as well. And we are, again, anecdotally, we're seeing shifts. Yes, it's still mostly Spanish, Somali, Arabic, and Nepali, but we are seeing, and I'm sure you're experiencing significant shifts in the non-English speaking families that we're seeing with what's going on in the world and who's immigrating and who's coming into contact with us now.
Yeah. And then just to add to what you were saying, patients and families they are a huge, stakeholder in this. And we actually did try to give feedback before we developed the instructions. However, just barriers kept coming on, like how do we contact families? We need interpreters to help us with that. We need to deliver the instructions. And so that became a little complicated. And then we added part of it add that piece as part of our prospective data. And then just going over, just adding to what you just said in terms of the prospective study, I mean, we've, I think, have screened over 330 patients already since this summer, and we have consented and enrolled about like 94 patients, English and non-English, and of those about like 25 are non-English, including of all the languages. Most of them are Spanish, one is Arabic so far, and then a few are Nepali, and like 6 are Somali speaking.
Thank you, Rick and Dulce. I mean, there's so many layers to talk about here. One that I think that caught my eye is how, towards the goal of training the next generation of more culturally competent and adept physicians and APPs. What have been your thoughts about how to integrate part of what you learn in the curriculum or the sort of learning material for fellows and APPs who are the frontline people who will discharge these patients?
I feel like that was you were like a plant. So one of the things that we've done with, and certainly spurred on by Maria's experiences and by what we learned with this project, wearing my other hat as co-director of simulation for the Heart Center, we actually designed an educational module with our staff and APNs and sort of a multidisciplinary approach on how to employ interpreters in an acute care, an acute event in the hospital. We had fantastic participation from our interpretive services as well. They made themselves available for all of the simulations and were able to give immediate feedback on, when should you call us? What's the best way to use us? What's the best way to sort of some best practices on communicating through an interpreter, making sure that you're making eye contact with the patient, letting the interpreter do the interpretation, but making sure that the patient, the family are seeing your nonverbals. So it was actually a great experience. I think we had a really good turnout and a lot of good learning through that. And I think that's one modality that we can employ and disseminate further throughout the institution to help people understand how best to employ the interpretive services as a tool and as a partner in delivering healthcare.
In addition to that, we have other projects here to come that we are working with. I looked down there because Ty is down there, and she's part of the health equity department here at Nationwide Children's Hospital. So we have a few other projects that will be coming soon, and one of them we would like to, for it to become a mandatory learning for everyone here at Nationwide Children's Hospital related to health equity and what we have learned, not only from this project, but other things that I have lived and experienced and that families have shared with us.
Thank you.
Thank you.
Thanks. We have just a few more minutes left. I have a couple of questions from the online audience. One of them has to do with MyChart, and they said, the question was, is there any intention of having interpreter services help us with responses to MyChart questions that families may send?
It's already in process. I mean, we already have some, I wasn't obviously part of that project, but I'm aware of that we already have, at least for Spanish. We have, if a parent has a questions, they can write it in Spanish. I think the interpreter has like 24 hours, I think, a limited time to reply back after they've discussed it with the provider or whoever needs to answer that question. And I believe they're working on multiple languages, but Spanish is obviously our most common one after English.
A couple of people actually asked about TeachBack, and they were asking about, is there a system and/or will there be some objective measures that you guys maybe incorporated into your study about how effective the instructions have been for the families, how well they understand things, et cetera, before they leave?
That is part of that's part of the prospective study is sort of an evaluation. It is obviously going to be subjective, but a subjective evaluation of how families receive the information, whether it is understandable, whether it's accessible to them. And so knowing that we'll have that data both at the time of discharge, and we're also asking them at the time of their clinic visit whether or not they felt that the information they got was helpful, whether when they got home they were able to use it and access it and felt comfortable with it. So we are trying to ask that question.
And also from the nurse's standpoint, we have, one of the things that we discussed was that there was poor documentation of review of instructions and also poor documentation that interpreter was used. So we are working with the nurses so that we actually develop a new DAF phrase for them to be able to use at the time of discharge that kind of reminds them, what type of interpreter did you use so that they can ensure that they're using the interpreter and also documenting. And hopefully, that'll help documentation overall, because at least when I learned, when I was a nurse, a bedside nurse, I learned that if you don't document it, it's like it never happened. So hopefully that'll improve as well.
And in that vein, the caregivers who are providing the information via the translators or interpreters, is there a way that we're sort of monitoring that and how well they're doing that, and whether the caregivers are actually understanding what's going on and asking appropriate questions and giving appropriate advice?
Well, we're not necessarily, I think, monitoring. There's ways we actually can get interpreter reports to see if interpreters are being utilized. So there's two ways of kind of assessing that information. But one of the things that I have been hearing from families, and our families are being randomized, or non-English speaking families are being randomized to be approached. And so part of that, as a research team, we have to kind of at the time of admission, at the time of discharge, be able to ask questions to the families. And they have actually expressed a lot of very, very key points, such as we have a Nepali-speaking parent who said yes to the study, who actually was saying a lot of people think that I know English, but I actually need an interpreter to understand things. And so it's well, that keys me in. Okay, let me talk to the nurse, make sure you're using the interpreter. Just because their families have some limited English proficiency, that doesn't mean they have medical understanding of the of that content in English. And then also along the lines with that, families just have been able to, when they come back for they were admitted for a procedure but came back for they came in for a cath, came back for a surgery, they have been saying how thankful they are for the instructions. So we are getting some feedback, although not necessarily objective, subjective.
And then in the last minute, the last question, last but not least, is cost. This is certainly not a free endeavor, and there may be concerns that if this becomes an expectation, it's going to be a costly endeavor.
Yes, if this becomes an expectation, it's going to be a costly endeavor. I mean, the thing is that I would turn that question around and say, how many patients are you willing to have a bad outcome just so that you don't have to spend the money? Perhaps it's a bit cantankerous. You know that I like to challenge. So yes, there is certainly a cost that's going to be associated with this, but number one, the volume of patients is not going to diminish. The volume of non-English speaking patients is only going to increase. And these aren't a lot of my family lives in a part of Miami. I'm Cuban. A lot of my family lives in a part of Miami where you can be born and raised and never have to speak English except at school, right? The stores, the signage, everything that's provided to you is provided to you in Spanish. But the reality is that our patients, our families are going to come here. They are going to initially not speak English, but they are going to want to learn and need to learn. And so this is an intervention, I think, that the growth of our population, if we're going to say that we really are trying, when your kid needs a hospital, everything matters, then this is a thing that we're going to have to put our money and our money behind.
Yeah, and it clearly aligns with our strategic plan as well from the hospital standpoint to decrease these disparities to improve outcomes. Thank you so much for this presentation and the engaging discussion. We are adjourned and we'll see you next week. Thanks.
Thanks, everybody.
Thank you.